All right, welcome, welcome, welcome. We're going to let people stream in. All right, and if you're here and just landing, open up your chat and let us know where you're sitting now. We want to see where people are coming from and where people are receiving this. We're going to make this a really interactive session. Indianapolis, Greg, excellent. Jill, hey, Jill, how are you? And from Florida, Michelle, New Jersey, outstanding. So welcome to This Clinical Life, presented proudly by Practicing Excellence. In this podcast, we explore the transformative impact of developing your healthcare workforce, a powerful yet often overlooked catalyst to positive change in healthcare. So today I am thrilled and honored and really, really excited about my guest and my friend, who one or two of you may not know, but Jason Wolf, the famous Jason Wolf. How are you, man?
To my mom, anyway. I appreciate that.
So, no, I've been a big fan for a long time. We've got people from all over the country, but Jason, for again those one or two that don't know Jason, Jason is president and CEO of the Beryl Institute, an organization committed to transforming the human experience in healthcare. He is also founding editor of the Patient Experience Journal, the first open access peer-reviewed journal committed to research and practice and patient experience improvement, with readership in over 200 countries and territories. I'm glad he added the territories because there's only 195 countries in the world.
Recognized, yes, 100%.
So
Google tells you crazy things when you search that.
I know, and now we have access to all information at all times, so we can't fool anybody. So.
Right.
But the point being is that Jason in our pre-conversation was saying that only 5% of all healthcare is delivered in this country. So there's much work to be done. So let's begin. And again, hey, Jenny, so many familiar names. So welcome everybody to This Clinical Life. I'm going to begin by asking your origin story. I mean, you have dedicated your life to transform the human experience in healthcare and have done unbelievable work to advance that cause. Tell us, our listeners, how this all began for you.
Yeah, I appreciate you asking. And I think, that to me is one of my most favorite questions to ask most people, because I don't think there is one common journey to this moment that finds us all sharing this common purpose around transforming the experience in healthcare. And I don't know that I ever thought I'd be here, to be honest. I mean, I started out with a passion for international relations. So I'm a trained diplomat first and foremost, who actually found my way into work culture and change, and really saw the value of the both interpersonal relationship and the boundary relationship between entities, so organizations or countries from a diplomatic standpoint, and realize that's how you accomplish things, right? You don't win through war. You build through collaboration and sharing of ideas, through the relationships that you build between people. And so my early career led me through this interaction between work culture and change and diplomacy. And when I found myself in a couple different industries, it was, the question really bugged me, because I was like, what are we making good in the world in all of this? And so it really led me to healthcare, almost accidentally in some way, where I realized you were making a difference in the lives of people in particular. And so it wasn't really until then that I realized what inspired me either, which were healthcare stories. One of my grandfather, who was a pediatrician who studied, in sort of the William Osler model of patient-centered care. And when I was young, I got to hang out. I guess we wouldn't do this as kids today, but I was hanging out in his waiting room at his pediatric practice, because it was a fun place to play. I guess, that's probably why I don't get sick too much. But, and it was always amazing. My grandfather as a person sometimes scared me, but I remember vividly how he would always come out for every patient himself personally and get down to the knee of that child that he was about to visit with, and introduce himself or ask them how they were doing or have a personal conversation before ever bringing them back into his exam room. And so I wasn't aware of it at the time, but here was someone personifying, building that relationship and seeing someone where they were. It wasn't the parent or the family member. He was down on the knee on the floor asking this child what puzzle they were working on or what toy they were playing with. And fast forward, a few years after that, in high school, my grandmother, who helped raise me on my mother's side now, so I get balance from both sides of my family. Was one of the early cases in the early 80s that was diagnosed with Alzheimer's before they really knew what to do with it. And she was such an influential factor in my life. She made me study and didn't give me Twinkies till I did. Um, but she really helped me see the purpose of why learning and caring for others. She was a teacher's aide, and made that important. And then she came down with this disease that she went from a human being I could interact with to someone that kind of just vanished into the ether, but was physically there. And unfortunately, early on, people didn't really know what to do. We we took her to a nursing home. And I remember, I would go regularly to that nursing home and, watch my grandmother not be able to do anything and see this staff come in every day and simply just roll her over. I don't remember people calling her by name or even acknowledging her as a person. Just so much roll this lady over so she doesn't get bed sores and we have to deal with that. And I just remember that this feeling of her being treated like literally a piece of meat. It's horrible to say. Until one day, this one care provider, this nurse came in, and I saw her put her hand on my grandmother's head and just kind of brushed her hair. And I even saw like a glint in her eye at that moment. She said, "Hey, sweetie, I just want you to know we're here for you. And if you need anything, you let us know." She wasn't going to do that, but this woman acknowledged her as a human being. I remember like physically feeling emotional in that moment, like finally someone recognized this human being who made me who I am, even at that age of 15, 16 years old. I didn't really connect those stories till I found myself in healthcare and realized that what was most important to me in anything that I've experienced in the world is how we care for each other. And in particular, in those moments, whether we are providers providing care or we are that family member or loved one in a bed. And so those were my catalyzing moments, sort of the cathartic insights that sort of led me to this path. And then I found myself in healthcare struggling with how to get it done. And honestly, I think the healthcare organizations out there are still struggling. We play numbers games and spreadsheet games, and we're better than you are games often. And, for me, the dream was I was in an organization I couldn't get people to collaborate. I said, wouldn't it be great if we created a place that people did? And so really, long story short, evolved the Beryl Institute, a place where people could come together on the basis of wanting to share ideas, on wanting to make healthcare better for the human beings that are in it. And crazy enough, that's been just shy now here a few weeks of 14 years since I left the delivery side of healthcare and walked out the door and said, we can do better. And then it's been so many of you that I see, like you said, Stephen, names in this room that have been part of that journey that made what's possible today. So it really is this interesting alignment of all of those things that kind of have me sit in this chair and be talking to you today.
Well, it's such a powerful story, and thank you for sharing it. And the simplicity and the transcendency of making a difference in the lives of those that are beside us. It could be a teammate, a colleague, somebody we're leading, or a patient in front of us. And the simplicity of those things manifesting as a part of an organizational culture, and the seemingly impossible task that we often feel of how do we get American healthcare and healthcare in general to manifest that as a non-negotiable cultural attribute, which is, what I'm deeply committed to. I know you're deeply committed to. And you would think something so powerful and so transcendent and so restorative for the giver and the receiver of humanity in healthcare.
Yeah.
Why do we have such massive variance around it? So a question here a number of years ago, and I just reread it, I think for the fourth or fifth time, the Human Experience 2030 paper, which is a fabulous sort of summary of distilling themes and actions from really thousands of healthcare leaders and distilling it into the priority of the experience of the patients that we care for, the experience of a care team member, and the experience of the community, all laced around humanity, compassion, and care for one another, and some key actions that were recommended regarding systemness and a variety of other actions to bring that to life. Since that paper was finished, which was right around the beginning of COVID,
Yeah, like smack
health.
dab at the start.
Right. So it was right 20, it was like 2020 that you came
Yeah.
out with it. And since then, it's been like 4 or 5 years or
Mhm.
4 years
For
since
years.
then. Yeah. And since then, we've had things happen to healthcare. So
Hmm.
the pandemic, the margin pressure, the burnout crisis, the workforce instability. How would you, from your perspective, characterize our progress on the humanity journey, how we are for patients, how we are for each other, uh, and that human connectivity, purpose-driven life that we're seeking? How are we doing on that front?
It's interesting. I don't know if I would give us a grade, even though I'm an old graduate school professor. I think, I appreciate you mentioning the HX 2030 paper. We did all this research. I think like many of us, it was late 2018 into most of 2019. We released the study beautifully timed in January to February of 2020. And in many ways, to your point, it was predictive of what we've experienced and where we are, because it actually acknowledged the challenges that we had been living in prior to the pandemic, right? The reality that there was a rise in, whether you think it's a dirty word or not, consumerism in healthcare.
Mhm.
There was a recognition even then that there was burnout and issues of well-being in our workforce, that we had disparities in the outcomes in healthcare that were recognized and acknowledged in evidence based on the way we practiced our craft. And we had to care for the communities in which we operated healthcare. I think the pandemic, in many ways, catalyzed our awareness of those. It wasn't as if we discovered something new, right? It was really that I like to say we did a little bit of sort of social archaeology. We dug away the crust that in many ways had covered up those issues because they were so vividly thrust in our faces. And then as a result of, I think, traveling that journey, like you said, we've been faced with all of the challenges, right? We have recognized we probably haven't been as good at listening to our patients and acting on what they say. We clearly haven't done the things we should be doing to care for our workforce. We need to be more aware of the needs of our community and the challenges of equity and disparities that exist. And so I think the reality is that the pandemic, in a way, I guess the eternal optimist in me gave us a bit of a gift of, it dusted off the mirror that's been in the attic for a long time for healthcare. It made us look really hard and fast at the things that are challenging us, and it really brought them to bear. And I would say that both two things about healthcare that I think we prove to ourselves throughout its history: we're resilient, um, and we're unwilling to give up. And if we were, if we were not resilient or we were willing to give up, we wouldn't have the healthcare system we have around the world today. And I think what we've learned in this journey is that the resilience is there and the innovation exists, but we're tired. And so I can't grade us on how well we're doing because we've been through such an exhaustive journey. I'm kind of a driver myself, Stephen. I mean, I run marathons, do cuckoo things like that. And the thing that I think they tell you, these trainers say the most important thing is actually to take a day off, right? After versus just keep going. We don't have that space in healthcare um, with intentionality. And so I think that, the way I would assess where we are is that we have to give ourselves a bit of a break. Um, and not that we can stop. That's, I think, the premise of our work. There's not the person that comes next that deserves any less than the person that came before. There's not a out of office sign or we're closed from 5 to 6 in healthcare. It just doesn't exist in most settings, right? So we have to find ways to give ourselves space. And I think that's where our opportunity and challenge is today. So I think the struggle that we're facing that you're, I think, touching on is that we're still working on how to give ourselves a break, if I can put it more clearly, right? And creating that space to take a breath and finding a means to support one another and reaffirming the choices that people made in having this be their profession in the first place, and then acknowledging the challenges of our community members, right? And so I think, all in all, we're doing a pretty good job facing the headwinds. But we have to acknowledge, like you said, the challenges that exist. We see diminishing resources. We see workforce that is, like I said, exhausted and not sure they want to do this anymore. We're struggling to find new people to fill those gaps. And we are still perpetuating a lot of the disparities that we tried to fix. So we're not perfect, but I don't think we've given up. And I do think we need to give ourselves a bit of a break in how we move forward as well. So I don't know if I answered your question, but that's kind of where I see us right now.
No, I think it's a complicated issue, and I think the impact of the pandemic and all that healthcare has been through has brought to bear many of the things that you spoke about. It created awareness of care disparities that became front and center and quantifiable. I think that I'm hoping that the process has restored the priority of caring for those that are caring for our patients. And I'm hopeful that the idea of creating purpose-driven organizations, because every piece of data that is emerging peri and post-pandemic is saying that people working in healthcare want to be in a place where they feel like they're making a difference in their lives. And people demand that in and out of healthcare. I think the post-pandemic existence is life is fragile, life is short, life is uncertain, life is crazy. I want to live my life in a way where it has meaning and purpose and impact. And if the pandemic moved that notion forward and we were able to create that as a way of being within healthcare, then perhaps we will benefit from these really tough last 3 to 4 years.
Yes.
I want to pivot a little bit. I want to ask the question that was referenced in your paper regarding certainly how do we advance the experience of patients? And that's core to what we both believe in. Almost every person on this podcast is going to say, yeah, we want to do that. And advance the experience of those that are providing care, our nurses, our physicians, our care team members. Those are two different but related organizational strategies. Yes. My question is, which one comes first? And how do we approach those? Do we do them differently? Do we do them the same? What are you seeing as successful out in the industry to pursue both the experience of patients and the experience of care teams? What are you seeing those that are doing it well? What are they doing exactly?
Well, I'll chunk this in a couple things and then bring me back if I get too far off the question. I mean, I think that the definition of patient experience, as we have spoken to it from the very beginning of the Institute, created by the few people we could gather in the summer of 2010, is this idea that experience is the sum of all interactions shaped by an organization's culture, right? And so from the very beginning, I think the point being that you can't deliver on any experience for anyone unless you build the kind of organization and the culture that perpetuates the capacity to do that. And so right there in kind of lies the answer, right? I think many people have heard me say, but I'll never stop saying it, the fundamental principle to me in this whole conversation and in healthcare is we are human beings caring for human beings. And so they can't be separated. So there are these two streams, like you speak to, around strategies for the experience of our patients and families and strategies for our workforce. But I think at the end of the day, there's more commonalities than distinctions, right? If we believe in the premise that the kind of organizations we build and the cultures we perpetuate enable us to provide the best in experience, and we're human beings on either side of that interaction, of that encounter. And so fundamentally, we have to kind of start from those core constructs from my standpoint. And I think, if you break it down from that level, people as human beings sort of seek the same things. What we find in asking the general consumers of care, just people on the street, not even just patients in a waiting room, but just the people on the street, what they want from healthcare, we consistently hear, listen to me, communicate to me in ways that I can understand, treat me with respect, be clear about your plan and provide me some confidence in your ability to do the work. You know what? If we ask those same questions of the workforce, what are they going to tell the organization? Listen to me, right? Communicate to me in ways that I can understand. treat me with respect, and then, hear my voice and act on it. So the fundamentals are not tremendously different. And I honestly would say, I think in many ways we have overcomplicated it, to make it feel more burdensome than we need, right? This idea that we have to care for each other and care for the human beings in healthcare, be they patients and family members, care partners, or the workforce, are tremendously integrated. Now, I would say this, if you ask the chicken and egg question, right? And I think that's an important one. I will say, and I believe that we can't care for others unless we care for ourselves. So you can take that how you want, right? And that could be a family caregiver caring for a loved one who's sick, or it could be a physician that's caring for a patient. It could be the housekeeper that's trying to work 3 jobs to make ends meet, who's coming in to make that patient's room clean every day. So if we're not caring for the people who show up every day, then we can't provide the experience that matters. And I think that's a fundamental truth. And I will, and I'm willing to put a stake in the ground around that one. That, for far too long, I think early on, when the experience conversation was about the scores, we were talking about this before. It was a thing, or it was framed as a thing to do. Like, oh, we do experience, or this checklist of things. We got to get our scores. And so, one, it became not something that was around, like you talked about before, this purpose that brings people to healthcare. 2, it became another action on top of a list of to-dos for people who show up to work every day. And 3, it didn't consider any of the needs of the people who did show up to work every day. So we were literally asking people in healthcare early on in this experience journey just to go do things for other people that it was evident we weren't doing for them, right? And so we could say, oh, we've got employee engagement surveys and all these kind of things. But I think back to your point on the pandemic, what it helped us see is if we don't care for the people who show up every day, our experience, pardon my French, is going to stink. I was going to use another word and I pulled back. But I mean, the whole idea that we have to care for those who show up every day and create an environment where they flourish, feel cared for, and can live their purpose, it is where we have to start.
Well, yes. And what I hear you saying, and certainly has been my lived experience, there's tremendous transcendency and human-to-human interaction that can be applied between clinician and patient in the exam room, between manager and their led team, between executive and direct report. And it is, I mean, Jason, it's all the same basic fundamental tenets and what I refer to often as simple rules. They are the simple rules of this organizational culture of how we interact with each other. And it was funny, just a quick story. Early in my journey of sort of coaching clinicians to advance the experience of patients, I did sort of a survey of patients saying, what do you seek and how do you define the best clinician that you've ever had? And it was, listens to me, cares about me, keeps me in the know, treats me with respect, knows me and what matters to me. I have confidence in their ability. It was just a very simple, discrete, consistent, every single clinic or patient was saying the same thing. And then we went to go and listen to our frontline care team members to say, how do you define the best manager you've ever had? What do they do exactly? It was the exact same thing, as you said. So, this idea and this notion of building clear, simple rules of what it means to be us and how we treat our patients and how we treat each other, and have it cascade from the CEO to security services and everybody else to saying, this is what it means to be us. It seems simple, but I don't
No,
know.
I think you're right. I mean,
It's so complicated and difficult
yeah,
to do.
we overcomplicate. I mean, we're good at overcomplicating healthcare. We're a science field, right? I mean, and we're an
Right.
industry on, evidence and science.
Right.
So we like our complications. But I mean, I think that this idea of making things simple is so fundamental, and it's universal. I mean, to your point, we're global. I don't know. We haven't really studied experience on other planets, so I might be mindful of that word, right? But I mean, we literally this next week, and we were talking about it this week with the team, we're releasing a study that we did with a partner in Brazil, a consumer study of the Brazilian healthcare culture, right? So completely different language, completely different healthcare system. But you know what? when you stand there in the room in Brazil and ask people how many people are human beings, they all raise their hands. And those same items you just listed
Right.
are the same things that are important to people in that healthcare system as well. So there are these global truths, right? These simple rules that I think can help us elevate healthcare. And it's not about, the being nice satisfaction thing, right? Experience is really what people take with healthcare. It's what ensures they, follow their care instructions and take their meds. It's what reduces safety incidents. It's what, enables people to choose us for healthcare and supports the bottom line impact of our organization. So I think when we make it a to-do for people, like I said, we lose the fact that it is actually something that I believe is so fundamental. It's not something we do at all. I think we're alluding to, experience and the way we operate our organizations is who we are. It's how we want to be. And if it's an initiative or a pillar or one of these things, then it becomes just one thing among other things we have to do. And I don't think we can actually distinguish it in that way, because I don't think there's anybody that deserves any less, right? So
No, and I think that there's another wisdom that emerges from that is that every healthcare member I've ever met wants to be the compassionate, helpful, listening collaborator and partner with teammates and patients. There's no physician I've ever met that says, I want to confuse patients. I want to make them scared and uncertain and worried about my competency. No, everybody wants to be amazing for their patients and their colleagues. And what we have found is that when clinicians, whether it be nurses, physicians, APPs, or any care team member, live in accordance with what they believe to be right, their sense of joy, purpose, and contentment in life can be transformed. So, and again, Steve Treziak's book, Wonder Drug, has really brought scientific vigor to that, to say, if we make a difference in the lives of those that we care for and do it in accordance with the things that we hold most dear in our soul, is what makes for the my life is what I hoped it to be. And so a couple of other questions that I'm curious about. Again, everybody on this podcast is wanting to advance the experience of patients and the experience of care team members. There's tremendous transcendency on the actions we can take to create impact on both, on how we lead, how we collaborate with each other, and how we connect with patients. There's lots of consistent actions that happen within organizations that advance both of those. One of the things that I'm curious about in terms of what you're seeing is, what do you see in terms of the impact of a patient experience cause and effort and strategic stake in the ground priority, meaning we want to be the best we can be in the experience of patients. What does that set of actions and strategic pursuits do to the experience of those that are providing it? Meaning,
yeah,
I'm a part. Yeah. So anyway, I have some thoughts on that, but I want to get your.
no, I love it. No, I mean, I think, to me, that's the whole value purpose, right? I mean, everybody says, well, what's the ROI of experience or the value? I mean, we're actually about to produce a paper on the value case for human experience, because it's important to elevate exactly what you're saying, right? That if you commit to a strategy, an experience strategy, like we said, you can't pull these pieces out, but by enacting it, you create the space to the very point you're making before, Stephen, like people can live their purpose. They choose this work for a reason. And so, I've always believed in, like, again, from a preacher approach, like of a positive spiral. I kind of call it that purpose spiral, right? When you're in an environment that allows you to live your purpose, you give it back, which creates even a higher level of that. And so you can kind of create this positively outward spiral of kind of living purpose and the outcomes that are a result of that. I think organizations that commit to an experience strategy have to build both backwards and forwards, right? Like we said, you can't build it on nothing. But you start to see all the outcomes we were just speaking to, right? You see outcomes on, and I think at the heart of our work will forever remain what happens for patients, family members, care partners. So those are safe, high quality outcomes, or at least the ability for people to live the rest of their lives with dignity and respect. It reduces issues of, readmissions. I mean, you can get into all the tactical piece. I know Stephen talks about this a lot, and he's got such great data to back it up. But it also it has the residual effect of impacting the workforce in terms of people choosing that as a place to work. Turnover rates, which are extremely expensive for organizations. So you've got this balance of quality safety measures, loyalty and choice from the patient family side. You have retention and attraction from the workforce side, but it goes even further, right? It has real bottom line implications for the way we operate. You find process efficiencies start to emerge because people are communicating with patients more effectively and each other. You start to find that leads to cost reduction or less use of supplies. I mean, there is this ongoing ripple effect component that builds out. And I also see that it has the community impact as well. So these kind of 4 value buckets to me are the outcome of any investment in action for experience, from the patient and family care partner to the workforce, to the business and bottom line, to the community impact that we can have. And that all really is filtered around that purpose spiral, that in living what's important to us, we're able to deliver on something that matters to others and really achieve the outcomes that matter to people.
Well, those are such important observations. And we have found in our research at Practicing Excellence, we had done a survey of over 500 healthcare leaders and clinicians. And we found exactly what you're observing, which is our leaning in to advancing the experience of patients in an authentic, purpose-driven, cause-driven way, not improve our patient satisfaction scores, which makes everybody want to barf. And Margie, you had a great comment here, and I'm going to address that in a second. But if we can get an authentic commitment to transforming kindness and compassion for every patient every time as a part of who we are and what it means to be us, if we can do that in a way that's really, truly authentic, we found that those clinicians who describe the places where they are as authentically committed to what's best and right for patients, their probability of burnout was 4x lower than clinicians who felt like an RVU center.
100%.
So, and you ask any clinician, what's been your best moment you've ever had as a nurse or as a physician or an APP, they will tell you they made an impact in the lives of those that they serve. And sometimes it's in the context of total clinical failure, and they went to a memorial service for an avoidable death or a loss, but they made a human connection. They made a difference. They were proud of themselves in that moment. And so when we talk about how do we leverage the experience of patients to restore the workforce, you're right. It's both. It's like 2 strands of DNA. And so they're a singular initiative with different substrates, and are both so important. And I want to ask the question that Margie asked here. Margie said that the metrics and reimbursement pressures have turned clinicians off when it comes to patient experience skills. It's almost like the experience is a dirty word when it's brought up to clinicians. Tell us your take on that. Thank you, Margie,
I think
for posting that. But I want to get.
I love the point, and I mean, and her second point. Yeah, I think your second point really, Margie, around the quality and safety. I mean, if you ask so building backwards from that point, if you ask a patient and family member to separate quality and safety from what they see their experience, they don't. We do that for ourselves to operate healthcare to make it easier to do, which gets to your dirty word point, right? We have siloed all our functions in healthcare to operate healthcare for us, the operators of healthcare, to make it easier. Patients and families don't distinguish quality and safety from experience. It is their experience. So, if we can get off of that forever, I'd be so happy, right? Because it is. But quality safety is what people want, and we should drive for it every day in healthcare. And that is part, I say, of the experience. And I want to invert what a lot of people would argue. Well, experience is part of quality and safety. That lens, I would say also, because we said we push a little bit here, Stephen, is I think a US-centric survey-based measure lens to the point of measurement metrics. Remember what we said, 5% of the world lives under this CAPS domain world in the United States. It is not the end-all be-all of how people decide their priorities in healthcare. And so when experience seems to be about what score did you get, physician X, or what did you do, unit Y, we have failed because we have made experience about something it's not. Right. It's not about the scores on a survey. It's not about the scores in a survey. And if I hadn't said it, it's not about the scores in the survey, right? That's one indicator that we have to understand what people do. But there are physicians around the world, there are healthcare organizations around the world making this a priority without having to have the motivation of policy directive or reimbursements be part of why they choose to do it. So I think the realities of that point is it becomes a dirty word if we make it back to what I said before, a thing to do or about how we grade someone's performance. Because I think, right, Steve, if you talk about your days in practice, right, if someone told you weren't providing good experience based on the score, you'd tell them to go wherever, right? Because I'm trying every day to just provide good care for my patients. Don't show me a spreadsheet and tell me I'm giving a good or bad experience. And I think we've created a false tension in particular around this issue that is actually torn at the fabric of what healthcare is ultimately about. We have, right, wrapped up in that very statement that Margie said, created the dynamics for sucking the purpose out of healthcare.
Right.
And it's going to be up to us to sew those seams back together. When we make the experience as a macro term, which is which is everything anyone lives through in their healthcare experience about them as a human being and about those who provide care as human beings, we change the narrative. And that is, I think, the obligation that we have in this conversation is the dirty word comes out of operationalizing surveys. It doesn't come out of the purpose that people choose this work for.
Well, and then, Margie brought up another good point about quality and safety in the integration of that. Now, I want to make one more comment on this that I think is important, is that we have tried to create policy and payer incentives to optimize the probability of something good happening for the patients that we take care of. And the risk in that is that we commit what we call surrogation, where we make the metric the mission. We invert the mission is kindness and compassion and safety and evidence-based care for every patient at every touch point according to their goals. I mean, that, the comprehensive, clinical intervention that advances wellness for each of the patients and the populations that we serve. But we try to create these metrics that are quantitative reflections of that. And by doing that, we make it about checking a box and we make it about achieving a score. And it becomes more about looking good than being good. And that inversion or the surrogation and making the metric a mission, ironically disengages clinicians and care team members from the very discretionary effort necessary to achieve the things are designed to help incentivize. And so this process of building, pay for performance and achieve this metric to get this percentage of Medicare reimbursement has disengaged the workforce from the purpose and authenticity that's necessary to transform healthcare.
It is an awesomely massive game of whack-a-mole.
Yeah.
And for anyone that's had small kids in their lives, you go to Chuck E. Cheese or someplace like that and just stand by the whack-a-mole and see how many people actually win that game, right?
Yeah. Right.
We're whacking at one thing and then it pops up over here. And so we are constantly chasing,
right.
That domain is too low or this score isn't right. And so we spend all our time trying to look good versus doing the things that we should to actually be good, right?
No, there's such important points, and I want to get your take on this. Jennifer Brodsky, I don't know if I pronounced that right, saying she challenged to say, so do we not measure? And my only comment, and Jason, I want to get your take on this, is that we are in a data-driven world, and we have to quantitatively reflect and verify that we're in measurable ways driving quality, safety, and experience. That's not what we're contending, but that is the child. The parent is our mission and our purpose and why we are here, as measured by, we can't allow the child to become the parent. We can't surrogate the two. We must keep first and foremost kindness and compassion for every patient, every time, kindness and compassion for every single teammate. Evidence drives everything that we do. Those are the parents as measured by quantitative measures that can verify that we're not just blah, blah, blah talking, but we're driving meaningful, measurable change. So, Jason, I'm babbling here, but I want to get your take on this.
We've started a point here, some energy with people, and I appreciate it. Yeah, I mean, the whole idea, as Tiffany was saying about patient stories and recognizing those moments. You know, if you go back and look at the surveys, and I know a lot of people spend a lot of thoughtful time building them, they tend to still ask us they tend to still ask about how we are doing. Like, tell us about us. So, you know, if you want to talk about a disengaging tool, right? If we go to a patient in a bed and say, we want you to tell us about us, right? So you've already told me you don't really care about me. You're saying, how do we do for you? So I think the measurement is necessary, to your point around data, but I would love, and we're actually working on a project in the global community. We've had like 1,000+ people contribute to what would it be like if we asked people what really mattered to them, right? So building off this idea that came from Susan Edmonds-Leviton's article in 2012, and I know Maureen Bossonano and has elevated this conversation through IHI, but like not simply asking what matters to you, but actually, do we ask people, did you feel listened to? Did we address what was important to you? If we actually had those data points from people, we would know we were doing the things that mattered because, like you said before, we know in so many different data collections that that's important to people who seek care and the people who show up to deliver care every day. We don't ask that.
Right.
So, I mean, I do think we should be asking the things that matter. And if we ask the things that matter, it gets back to all of these pieces that people are addressing. It helps us capture stories. It helps us speak to meaning. It still elevates the conversation and gives us a metric to achieve. But I'd rather know that someone felt like they were listened to in a number of places and find out the places that's not happening, so we can help, like you do so beautifully, deliver the skills that people need to actually be more effective listeners to the people they care for, the people that work with them. So there is a way, and I think there is a need for metrics that matter. Whether we have the right ones is a different question.
Yes. So there's a couple of things that I think are key points. There's another question that I want to close with. The idea and the notion, I think Richard had asked the question, you know, what skills can we deploy to advance the experience of patients, which is, you know, a really rich question. A couple of things that in my experience, and Jason, I want to get your take on this, is that we must keep the mission over the metric. The metric is a consequence of the actions that we take to render the mission. And we can never hold people accountable for a metric unless we give them the skills to move the needle. And so frequently I saw this for decades at numerous healthcare systems where care team members were accountable for a metric performance issue, yet they weren't given the help and the support and the development to move the needle on those very metrics. So, Jason, I'm going to get your take on what you're seeing in the industry in regards to the application of a people development strategy coupled to a metric that is a child, if you will, of a strategic imperative mission.
Yeah, 100%. So, I mean, I think, you know, I think you write the problem that we end up with sometimes is teaching to the current test, right? And I think that's where we fall short. And I think what you're speaking to, Stephen, is really the ability to teach at a higher level to the fundamentals of what matter. See, if I were building a strategy, if I were back in my organizational life building a strategy for what this would be for my organization, it's like, what's our stake in the ground? What is the experience that we believe anybody in our organization, patient, family member, care partner, or work member deserves?
Right.
And once we can all share that, what are the specific actions we're all going to take to get there? And what skills do we need to enact to take those actions? That's, I mean, it's to your point around simplicity, that's the structure by which I would operate. You know, if you did those things, oh, by the way, over here, there might be survey X or survey Y or survey Z, I would wager you're going to knock that thing out of the park, right? Because you made a commitment at a strategic level as an organization. You said what you expect everybody to feel, do, be, and then you help provide the skills to get there. So, and I think, as you can allude to, is not always the same in every organization.
Right.
There are some core fundamental pieces that we've addressed here, right? How are we better listeners? How do we communicate effectively so that people hear us in language that actually they understand? There are some fundamental pieces of that equation that would be so significant here. But I think if we teach to a test, like you said, is sort of the child in this endeavor, we're
Right.
going to always miss the
Yeah.
objective that we're striving for. And so I think I get the question a lot, and I think it's inherent in some of what people are asking. Why do we always feel like we're falling short?
Mm.
That's your answer, because you're teaching to something that's the foundation, not to the aspiration and what action should
Right.
be.
Right.
And so that's, I think, our opportunity. And I think the advice to leaders, to your point, then is if you're not willing to put a stake in the ground around the experience you want to provide in your organization for people who show up, either to work or get care, then you're lost before you start. You will never get the scores you want. You'll never be that percentile you feel like you need. So you're better than your buddy or your friend down the street. And you're going to forever be in this kind of wheel spinning moment where you're finally going to go, this experience thing is too much and we should invest in it because it's not working anyway. That is like that's the story of retrenchment and shrinking. That is the complete opposite of that purpose spiral that we spoke to. And those are the organizations that people are jumping off the ship, don't want to work for, are harming their communities. And we know the stories that are told about them. And so there's a huge opportunity here for people, I think.
Oh my gosh, there's so many there's so many great comments there. I just
I
want to
know,
dive into them.
yeah,
Each
it's
of
great.
them, each of them is the podcast. So, but we're going to wrap things up here in a moment. But you know, Jason, you provided such wisdom. Again, the power of purpose, the transcendency between the experience of patients and the experience of our care teams, and compassion, listening, encouragement, being there for one another, communicating effectively, honoring and respecting. There's just so much overlap. And if we were to create simple rules and guiding principles for how we are for our patients and how we are for each other, and couple those to big strategic priorities for kindness and compassion for every patient and honor and respect for every teammate, and then have uh, quantitative metrics that verify through engagement, through turnover, through patient experience, because that's the world we live in. We can't ignore them, but we see them as consequences of 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 what we're aspiring to do, and build a human development strategy to allow patient connectivity and team collaboration and even leadership effectiveness to manifest through continuous development of our people's capacity to render results. Just stir all that up in a bowl, and
Yeah.
out comes an elite
People are
healthcare
sitting there going, oh, you
organization.
make it sound so easy, right? But I mean, I think, we were talking about this before we got honesty. And I think the reality is that there are no secrets in this work,
Right.
right? And like back to the origin story you asked me about, one of the reasons I felt it was important we had a community that was a place where people were willing to share ideas is because I thought people wanted to hold the secrets for themselves. I mean, I think it is the generosity of spirit of folks like that are here with us
Right.
today, the work that you all do and the clients that you help support in their incredible achievements. Um, it's in that willingness to come together and share ideas that we thrive. And as we were talking about before, the distinction should be our commitment to execution. So, people are going to say, so what? All those things you talked about are not overwhelmingly impossible. They're in fact simpler than some of the things we've chosen to do today. But it's really a commitment to executing on some of those core ideas that make a difference. And I think we have to stop making the excuse that experience is just a cost and we don't need these people to execute on it. And so it kind of becomes the latest thing on the chopping block, right? Because what you say by doing that is that you don't really care. I mean, I hate to put it that bluntly, for the people who show up every day to get care or the people who work in your space. And you really need to invert that strategy, because if you lead from point of execution around exactly what you're saying, Stephen, that incredible stew that we just cooked there, you're going to reap all the results you want. You're not going to be having to manage in a world of pressure, dollars, and things. You're going to see things happen from a reality standpoint, both financially and otherwise, that will sustain organizations well beyond what you can do on a trajectory that leads you elsewhere. And so I think we have to just shift our strategic mindset ever so subtly and reprioritize this in a way that matters. So I'll just keep going on if I say
Yeah,
so.
I know we could, yeah, we need to like crack a bottle of wine to keep rolling, but I'm going to wrap up here. And I think my final comment is that we have full dominion over who we are in this life. And we can start with me. I'm going to start with who I am for the people that I touch. I will be a light in the world for my patients, for my colleagues, as a leader, and I can choose that. And that is immensely contagious. And you couple that to top down, strategic, purpose-driven, story-driven mandate coupled to a human development strategy. It gives you the possibility that this can happen. We have dominion over patient connection and our ability to collaborate with each other and how it is that we lead to create amazing organizations for our communities, for our care team members, and for our patients. We just have to make sure that we sometimes be attentive to the regulatory world that we're in, but not let it utterly screw us up in terms of what actually matters, because it will. Regulatory, I told you about my favorite oxymoron, regulating excellence, right? It's not
Yeah,
ever
right.
how it happens. So,
It
all
never
right.
really works out the way we would hope if we go that route, right? So,
Yes, yes. Well, Jason, I am deeply grateful for you, for your time here, for your leadership in this space, and all that you do to advance the experience of communities and patients and families and care team members. You are a light, as we say, in the world, and appreciate you, my friend.
it's a really honor to be with everybody, and I love the conversation. We'll have
Yes,
many parts, so hopefully we'll see you all together in the community at some point as well. And thank you, Stephen, for your support and all you do in really elevating this conversation and helping people do something about it. It makes a difference.
appreciate it. All right. Thank you, everybody, for joining This Clinical Life, and stay tuned for the next one. We are out.